Thank you very much. I want to thank the organizing committee and Professor Lee and the Korean Society of Transplantation for this invitation. My name is Daniel Maluf, and I serve Professor and Vice Chair of the Department of Surgery, University of Maryland. Today, I will address one of the most debated and evolving topics in transplantation, which is surveillance of hepatocellular carcinoma post-transplantation. The core question that we face today in the transplant community in this area are: what is the current and more reliable way to detect hepatocellular carcinoma after liver transplantation? Are we truly optimizing both sensitivity and specificity, or we are simply following long-standing habits? What is the optimal strategy from both standpoint, clinical and financially, or economic standpoint? This involves a delicate balance between early detection, cost effectiveness, and minimizing patient burden. And because hepatocellular is growing and it will continue to grow in the next few years, are we shifting toward risk-based pathways or pushing standardized global guidelines? I'm going to try to answer these three questions today as much as I can. So a little bit of hepatocellular carcinoma recurrence background. In the United States and also in Europe, the overall recurrence rate is 10 to 20% in general, and this is based on the degree of the Milan criteria as was developed. Centers more aggressive in transplant for hepatocellular carcinoma suffer from higher recurrence rate. Now, there is a change scenario in the liver transplant, at least in the United States and in Occident, is that the utilization of pump perfusion, machine perfusion, and normothermic regional perfusion has increased the number of liver transplants. This year, probably more than 12,000 liver transplants will be done in the United States. And more importantly, because some of those liver cannot be used for patients with high MES score, are being used for patients with hepatocellular carcinoma. So we're probably going to see an increase of the number of transplants in patients with hepatocellular carcinoma. It is estimated with all these changes will significantly increase the number of ACC patients in our waiting list and receiver transplant in general. The known risk factors, as we know it, are poor tumor differentiation, microvascular invasion, elevated biomarker or alpha-fetoprotein, aggressive or large tumors, and poor response to pre-transplant therapy. In Asia, it's not very different. Several papers from Korea have shown that the incidence also range between 8 to 15% or 20%, and patients with that are transplanted with very large tumor obviously is higher. And that has been shown in several papers, including the Korean Organ Transplant Register, the COTRI, that was published in 2021 with the incidence of recurrence of 12 to 20%. In terms of timing, could be early, could be late. Early recurrence is more common and usually is associated, very early recurrence is consequence of failed pre-transplant assessment sometimes, and it's quite important that pre-transplant staging is done correctly. Late recurrence is less frequent, and when it happens, they have better outcomes. In terms of location, as you can see, most of early are in the liver, but later is extrahepatic. So globally, it is expected an increase of the incidence of hepatocellular carcinoma as well as the number of liver transplants that will be due to hepatocellular carcinoma with expansion of transplant oncology, better downstaging techniques, immunotherapy, and the use of marginal graft, at least in the United States. Because of this, surveillance become especially important nowadays. A little bit of what we know about post-transplant surveillance. As we know, the peak of recurrence usually happens between 6 and 18 months post-transplantation. Post-transplant recurrence is most common at that time, where 70 or 80% of the recurrence occur at that point. And sometimes it's due to micrometastatic disease in the liver, and that get accelerated post-transplantation with the immunosuppression. Late recurrence happen after 2 years, as you can see, and it's less common. And when that occurs, response usually to the treatment are very well differentiated tumors. But what we also know that there's not universal guidelines that exist at this point, and every center follows their own guidelines. In practice, centers adopt protocols from general ACC surveillance, that most of them are pre-transplantation, or transplant society guidelines like the Korean Society or the ASLD. Early detection, though, it is important, and it's important because it really changed the outcome of those patients. That's shown by a paper by Dr. David Lee and colleagues, where they did surveillance data. It's a retrospective study by 3 large centers in the United States. And what they found that the cumulative exposure to surveillance of those patients in the first 2 years was related to a better diagnosis and a better outcome post-treatment of those patients. In this study, the median follow-up was 31 months, and the mean time of recurrence was 13 months. What they conclude is the surveillance scan in the first 24 months was associated with the ability of offer those patients different options for curative treatment. The other issue, study University of Hong Kong that focused in the type of staging post-transplantation. And this is what is the best technique post-transplant to follow the patient, to surveil the patient, but also when the diagnosis is done, how to stage the patient. Retrospective study, 189 patients, recurrent tumors, demonstrated the PET-CT scan was very accurate and sensitive in the staging of the post-transplant recurrence, and that allow an early and they allow a better option for therapy for those patients. Let's look a little bit about evidence-based current surveillance practices. This study for Agarwal that was done in 2020 in the United States, they did a survey, 101 transplant centers, which they received response from 48 transplant centers. What they found that 96% of the centers have surveillance protocols. So the big majority has surveillance protocol. 74% they do cross-sectional images, abdomen and chest, and 21% of the centers do just abdomen. 64 of them do check for alpha-fetoprotein, and the bone scan that used to be done frequently in the past is kind of going away. Most common images in the United States, at least based on this survey, is 3 to 4 months in the first year, every 6 months the second year, and yearly after. But that clearly changed with the race of the patient. This is the graphic representation of what the surveillance is in the United States. As you can see, the type of images, the surveillance duration, and the frequency where these images are done for patients that are low risk or high risk is very variable. And I think that the visualization of this tell you that it's not really very accurate data to come up with the perfect surveillance protocols. This is not different in Europe. In Europe, the EASL provides some guidelines and emphasize personalized surveillance based on the individual risk assessment and advocate for the standardized images and diagnostic protocols. When you look into Asia, it's kind of similar. This study that was published by Dr. Kim in 2023 also demonstrated variable practice pattern across Asia, focusing in patient risk stratification, especially in centers in Southeast Asia. Although ultrasound and alpha protein, in this case, was recommended strategy for HCC surveillance, the Asia Pacific expert panel concluded that Pikachu add value for those patients with alpha-fetoprotein negative tumors. Okay, the value of HCC risk stratification. Available stratification scoring system integrate tumor burden, biology, and patient factors to predict the post-transplant recurrence, post-transplantation, enable more accurate candidate selection, individualization, a type of surveillance, and optimization of transplant outcomes. Some of these are shown here. The RETREAT study, as you can see, is probably the most used in the United States, but there's several studies, including the MODEL study and more recently published the MODEL AI. The RETREAT study, a study that was multicenter retrospective cohort that was published in 2017, developed and validated the RETREAT score, a simple prognostic tool based on explant tumor burden, microvascular invasion, alpha-fetoprotein level, which accurately stratify the risk of hepatocellular recurrence. Importantly, patients with the RETREAT score of 0, their chances of recurrence in the first 5 years was less than 3%. Okay, RETREAT score 0, less than 3% chances of recurrence. And RETREAT score of 5 is above 50%. So that was very important. And this was validated by University of Toronto, which also has a large center with a lot of hepatocellular carcinoma. Here you can see in this graphic, the C statistic was 0.77. As you can see, patient with the RETREAT of 0, the chances of recurrence is minimal. 1, 2, you can see still very, very low. And some go, as the score go up, the chances of recurrence increase. This study was importantly recently validated in a very large prospective now study with 1166 patients from liver transplant patients that were transplanted between 2018 and 2022. 8 transplant centers in the United States. What they found that the 3-year cancer-free survival if the RETREAT is 0, it was 99%. If the retreat was 3, it was 84%. And if the retreat was 5 or more, the chances, the cancer-free survival was 56%. So you can see that it's very accurate detecting the chances of the patient to have recurrence. More recently, a group from Korea, tried to do a real-world validation of the retreat and pull the data from the UNOS database, almost 5,000 patients, and they had the same conclusion that demonstrate the retreat score was associated very accurate with the chances of HCC recurrence with the C index of 0.69. Importantly, what I captured in this study, and I'm hoping, I don't know if Dr. Kim will be here, but this is very important to discuss because if you look in the 5,000 patients that they pulled from the UNOS database, 75% of the patient has a retreat score between 0 and 2. 75. So the big majority of those patients has a very low recurrence, probably less than 3%. All those patients has surveillance for 5 years. And this is a topic that I was discussing today. Other score is the model of recurrence after liver transplant that was reported in 2018 by the group from New York. It calculated risk based on patient pre-transplant neutrophil lymphocyte ratio, alpha-fetoprotein, and tumor size. Has been shown superior to older Milan criteria and predicting recurrence. Now, in this study was not compared with the retreat study. A group from Korea published, actually from Seoul University, published this study where they add an AI model developed using a residual block-based deep neural network using 563 HCC liver transplant patients in Korea, and they found that using AI outperformed all the other scores that are shown in this slide. Importantly, because this continue and AI continue training eventually has the possibility to become more accurate over time. And I'm going to go very quick in terms of emerging tools. As we all know, biomarker has been for a long time used. Alpha-fetoprotein, PIPK2, and other biomarker has been used. The sensitivity and the specificity is variable. In general, more clinical centers or more centers use this in combination with images. Very few centers use this alone. Liquid biopsy on cell-free DNA. There was some discussion about the utilization of cell-free DNA. I think that definitely cell-free DNA has a lot of area to expand in this, still not used clinically, but there is several clinical trials going in terms of cell-free DNA. The clinical utility could be detect cancer in individuals at high risk, major residual disease following surgery, either resection or transplant, enable treatment selection, or getting more into the biology and elucidate mechanisms of resistance of disease progression. Later, I will present a little bit of DNA methylation. That is an area that we are working on, and we look at the methylation changes in the tumor and see how that predict the chances of recurrent post-transplantation, and obviously had to do with the biology, but we'll present that later today. In terms of core effectiveness and cost utility, as I mentioned, these 2 studies. Unfortunately, the 2 studies are not real world, but they are Markov studies, Markov model studies. One was published by the group in UCSF in 2011, and this one more recent was a group in Europe. It was published in 2023. Demonstrate using a Markov model that surveillance offers slightly survival and quality of life gains, and it comes with a significant increase in the cost. The key findings were marginal clinical benefit. Cost metric, it was 14,000 euros per life gain for a year life gain. And so they showed that the probability of being cost effective was only about in 42% of those patients. So the majority of the patients that get surveillance is very highly costly, and they really get no benefit over time. I think that this is a topic that is going to be coming up more and more frequent as the cost of liver transplant, as you all know, is increasingly significantly with at least in Western countries with the use of this new technology. So to conclude, currently there is no consensus in the best practice guidelines for post-transplant HCC surveillance. Most centers tailor protocols based on their experience and their practices. It is clear that risk stratification of the patient and emerging tools such as biomarkers and AI is coming, and it will probably be part of the very near future. high cost and low efficiency in the current surveillance protocol that we have it has been described in several studies, and there is a trend toward personalized risk-adapted surveillance to achieve optimal clinical and financial strategy. Now, this is my personal take on this, and I think that a lot of you will share this with me. Number one, it is essential to have a risk stratification done immediately pre-transplant and immediately post-transplant. And I think that we all do that, but we don't do it in a formal standardized way. So this is, I think, is very important to obtain good data for the future. And then the surveillance protocol should be tailored for that. We talk about in the low risk, intermediate risk, and high risk. There's no doubt that high risk patients need to have frequent studies in the first 5 years to detect early recurrence and be treated or retransplanted. The intermediate risk is variable, can be followed with different frequencies. And the low risk, there is some studies, including the recent published retreat update prospective study, that they propose that patients with low risk of recurrence shouldn't be any surveillance after the first 2 years. And this is made exactly for the step 3 that I mentioned here, economic optimization. I think that the intensive surveillance mainly for high risk group, but what you do with a low risk group, and this is definitely an open topic for discussion. I hope that you like my presentation. There is a few meetings coming from the ILTS that this topic will be actually one of the topic of focus. Thank you very much, Dr. Lee and the group. Thank you.